Welcome to this clinical walkthrough on the acute alcohol withdrawal case for UKMLA, brought to you by Mediate, your 24/7 practice partner.
Okay, so in this walkthrough, we're going to put you right in the hot seat with a classic but really challenging PLAB2 scenario. A patient who's in acute alcohol withdrawal and is demanding a home detox. And look, the challenge here isn't just about the medicine. It's about how you handle a really difficult conversation where patient safety is absolutely on the line. Let's break down how you can nail this.
So we're going to break this all down into 5 key stages. First, we'll get the scenario straight. Then we'll talk about your assessment, how to spot those all-important red flags, how to have that really tough conversation, and finally, how to pull together a solid management plan.
Okay, let's get right into it. Picture this. You're in your consultation room and a patient walks in. They're clearly distressed, and here's the story they give you.
So what you have here is a 50-year-old who stopped drinking yesterday, and they're already getting withdrawal symptoms. But here's the kicker. The bit of information you really need to hear. They have a history of seizures during detox. And despite knowing this, they're asking you for diazepam to take home. Right there, that's the core conflict of this station. You got to handle this safely.
Okay, so before you even think about prescribing anything or even saying yes or no, your first job is to just pause and assess. A really structured approach here isn't just about ticking boxes for the exam, It's about gathering all the evidence you need to make a safe and, frankly, a defensible clinical decision.
Right. A systematic assessment is absolutely key. First up, you've got to get a full alcohol history. What are they drinking? How much? How many units? Get the big picture. Next, run through the cage questions. Cut down, annoyed, guilty, eye-opener. It's a great quick screen. Then, and this is so important for this case, you need to dig into the withdrawal-specific stuff. Ask about shakes, but especially about that seizure history. And finally, you always have to do a quick risk assessment. How's their mood? Any risk of self-harm? This structure is your safety net. It makes sure you don't miss anything critical.
So that structured assessment we just talked about, think of it like detective work. It's not just a list of questions. The whole point is to uncover the red flags, the clues that are going to shape your entire management plan.
And let's be super clear about what a red flag means, especially in a PLAB2 station. This isn't just, a minor concern. A red flag is a deal breaker. It's a sign of a high risk of something really serious happening, and it means that routine management is absolutely off the table. The moment you spot one, your plan has to pivot.
So, from what this patient has told us, there should be a couple of massive red flags just jumping out at you. Number 1, and this is the big one, the history of seizures. That is a huge predictor of having another one. And number 2, they're already symptomatic. That means the withdrawal is happening right now, and the risk is climbing by the minute.
Okay, with red flags like these, there's really only one safe path forward, and it's totally non-negotiable. Home detox? Absolutely not. It is completely off the table. Your duty of care here is crystal clear. This patient needs to be in a hospital for supervised medical detox. And remember this for the exam, your decision is clinical, not a negotiation. You've made it. Now you just have to communicate it effectively.
All right, now for what is honestly the toughest part of this whole station. You've made your clinical decision. But how on earth do you communicate that to a patient who has just asked for the complete opposite?
Yeah, this is where your communication skills are really put to the test. You have to strike that perfect balance between being empathetic and being firm. You absolutely have to acknowledge their request, show them you've listened, but then you have to very clearly and calmly explain why that's just not a safe option for them. And here's a great tip. Start by using their own words back to them. Something like, because you've told me you've had fits before. When you do that, you're immediately showing that you've been listening carefully and that your decision is based on their personal history, not some textbook rule. It's a really powerful way to build trust, even when you're about to say no.
So once you've explained the why, you have to be totally direct about the what. Use really clear, unambiguous language. Say things like, you need to be admitted to the hospital, and we need to do this today. This is not the time to be vague. Clarity is safety, and mentioning an ambulance just drives home how serious and urgent this is.
But what if they refuse? This happens all the time in these stations, and you have to be ready for it. If the patient starts pushing back, you need to be prepared to gently, but firmly restate the risks. The key is not to get into an argument.
Here's a great little model you can use if they do push back. Think
Empathize, state the risk, and reframe the solution. So you start with empathy. I completely understand you're worried about going to the hospital. Then you state the risk in no uncertain terms, but trying to detox at home in your case could actually be life-threatening. And finally, you reframe the solution. The hospital isn't a punishment, it's the safest option, and it gives you the best chance to get through this safely.
Now, having a conversation like that, it's a real skill, right? And like any skill, you only get better with practice. If you want to try navigating this exact tricky conversation for yourself, you can practice this exact case right now and get objective feedback on Mediate.com.
Okay, let's move on to the management plan. So, let's say the patient has agreed to admission. What happens next? You need to be able to talk about the immediate steps and also show you're thinking about their longer-term care.
The immediate plan is all about two things: safety and a good handover. So, step 1, an urgent hospital referral, and it has to be by ambulance. You can't have them getting in a taxi and having a seizure on the way. Step 2, you need to make sure they're admitted under the right team, ideally a psychiatry or an alcohol liaison team, the real experts here. And then step 3, in the hospital, they'll get that supervised detox they need, with medication given in a controlled environment, and they'll start thinking about a proper rehabilitation plan.
You know, a good candidate just manages the crisis. A great candidate thinks about what comes next. Mentioning a clear post-discharge plan shows the examiner you're thinking holistically. And it shouldn't just be one thing. You want a multi-pronged approach. Things like alcohol counseling to work on coping strategies, maybe some craving reduction meds like acamprosate to support them, and, this is so important, linking them up with social services or addiction support groups. You're building a safety net for them in the community.
So, we'll leave you with this to think about. This case is a perfect example of that classic tension in medicine, right? Balancing a patient's autonomy, what they want, with our duty of care to keep them safe. So the question for you is, how are you going to navigate that balance in your next challenging consultation?
And remember, thinking about it is one thing, but actually doing it under pressure is another. You can practice this exact case now on MyMediate.com.